Moving on to the 9th plenary of our session on erectile dysfunction, the epidemic and correlation with cardiovascular diseases by Professor Ajith Malalasekera. To chair this session, I would like to invite Professor Neville D. Pereira, Senior Consultant Neurological Surgeon from Sri Lanka, and Dr. Dimantha De Silva from Teaching Hospital Karapitiya. Over to you, sir.
Our next plenary lecture is on erectile dysfunction, the epidemic and the correlation to COVID, CVD. Our next speaker is Professor Ajith Malalasekera. He is the consultant neurological surgeon attached to medical faculty at the University of Colombo. He's been a treasurer of our SLAUS for many years. So may I invite Ajith to deliver his plenary lecture.
Good afternoon, chairpersons and ladies and gentlemen. It's a non-surgical emphasis lecture post-lunch, so I will keep it hopefully short and sweet. As Professor Madhu stressed upon a little while ago, there is a massive burden of disease as far as stones are concerned in our parts of the world. And this is the same for erectile dysfunction, and also I will stress on it later for cardiovascular disease as well. So this is something that we in the South Asian region will have to deal with in the next few decades to come. Sexual health as an indication of general overall health and overall satisfaction of life has been understood for years and years. Even during the civilizations of the Mayans and the Egyptians, there have been attempts at treating erectile dysfunction using apomorphine, which is an extract from the lotus flower. Fast track to the present era, the drug which was patented as UK 92480, or the medication which led on to the beautiful blue drug that we are all familiar with and we prescribe very liberally, brought about a lot of satisfaction and happiness to many a men all over the world. Now, during that time, the Massachusetts male aging study, which looked at a large cohort of patients, of individuals for a long duration from 1987 to 2004 in the US, identified that over 52% of an age group, 40 to 70-year-old age group, had some element of erectile dysfunction, of which 10% had complete or severe erectile dysfunction. Closer to home, in a meta-analysis including 25 surveys in China, identified, this was a study which included about 48,000 patients, identified that erectile dysfunction was present in approximately 50% of that age group, of which again about 14% had severe erectile dysfunction. So what about the status as far as the men from our South Asian countries? There is a study published in the Journal of Sexual Medicine in 2014, and this looked at a cohort of South Asian versus those of European descent studied in England. And this identified that there was no statistically significant difference in the incidence of erectile dysfunction and also in ejaculatory problems in these two groups. So therefore, ladies and gentlemen, we have a significant problem even in the South Asian population. Now let's look at cardiovascular disease. What is happening in cardiovascular disease in South Asian populations? Now this is a large study conducted in the US, and where they focused on South Asian ethnic origin patients from India, Pakistan, Bhutan, Nepal, and Sri Lanka included. And what they found out that there was a disproportionately higher burden of atherosclerotic cardiovascular disease in this ethnic group. And they had a higher hospitalization and mortality rates due to this cardiovascular disease. It is so important that actually in their guidelines for for cholesterol and primary prevention of cardiovascular disease, they have identified South Asian ancestry as a risk-enhancing factor. So we know that there's a high prevalence of ED, and we know that the cardiovascular disease incidence is also very high in the South Asian ethnic groups. Now the projections for 2025 show that the prevalence of ED will probably be around 320 odd million worldwide. And the largest projected increase is supposedly will include us Asians. And so therefore, there is going to be a lot of work and a lot of effort to treat these unfortunate men in recovering from these diseases. Now, however, even though there is a large percentage of people with erectile dysfunction, even the statistics from the NHS UK shows from GP practice that over 70 to 90% do not actually receive treatment, and actually the GPs themselves may not question the patients who come with lower urinary tract symptoms, where there is concomitant ED in a lot of them. In less than 10% only will they be questioned, and over 80% will not receive any treatment. So that's something that we really need to address. So doctors don't ask, patients don't tell, and therefore these remain a neglected area. From the Princeton consensus recommendations, we have been told over and over again, these are some of the publications which were made in 2012, that there are common risk factors for cardiovascular disease and erectile dysfunction. Smoking, blood pressure, hypercholesterolemia, and diabetes, one of the being the crucial risk factors, and endothelial dysfunction being the main denominator. Now, we have understood this a little bit better over time, and in the patients with vasculogenic ED, mainly due to atherosclerotic disease, it has been understood that the presentation of erectile dysfunction may precede symptomatic cardiovascular disease by over 2 to 5 years. A big window of opportunity which as urologists we can utilize to detect and maybe primarily prevent cardiovascular disease. And this has led to the Princeton consensus actually recommending to consider men with organic ED as having cardiovascular disease unless it is proven otherwise. And they go on to indicate that over 80% there is a higher 80% increased risk of coronary artery disease, especially in the younger age groups. Now, what about ED as a harbinger of cardiovascular disease? I mentioned that it may precede the occurrence and the symptomatic presentation of cardiovascular disease by 2 to 5 years. And it is much more easier and a low-cost measure of cardiovascular disease than all the other CV cardiovascular biomarkers. So therefore, it is something that we need to utilize ourselves and push across to our colleagues and other our students as well when we teach in postgraduate and undergraduate curricula. In a large Swedish trial involving over 90,000 patients, where they looked at erectile dysfunction, the presence or absence, and they identified that cardiovascular events, myocardial infarctions, cerebrovascular events, and also very interestingly, all-cause mortality was higher in those with erectile dysfunction. And it was much more prevalent in younger patients and also in those who had intermediate cardiovascular risk, and also when it was interestingly identified by a questionnaire versus just questioning and asking them whether they had a erectile dysfunction problem. So another indication for us to routinely use these at least the abridged erectile dysfunction questionnaires in our practice to identify these people. Now, what about the effects of drugs used in cardiovascular disease on erectile dysfunction? Large studies, especially in Sweden, have identified that there are definitive evidences to indicate that any patient who has hypertension runs the risk of having, obviously they will be treated, and this risks them of having erectile dysfunction either brought on or worsened by the drugs they use. And this is immaterial of the so-called better drugs as far as erectile dysfunction is concerned. So even if they use the much more better drugs such as calcium channel blockers or alpha blockers and angiotensin converting enzyme inhibitors or angiotensin receptor blockers, even despite the use of these drugs, they have a higher risk of getting erectile dysfunction as a side effect of these medications. So what about the reverse? What about the drugs we prescribe in these patients with erectile dysfunction? Do they have a beneficial effect on cardiovascular disease? There is definitive evidence emerging of beneficial effects for the cardiovascular system. And some of these will depend on the endothelial dysfunction, vascular aging or vascular stiffening of vessels, and inflammatory activation, ventricular remodeling, and protection against ischemia, reperfusion, injury, etc. Now, there have been large studies, again conducted in Sweden, with the populations, study population being around 90,000 or so, where they have identified those presenting with myocardial infarctions and being on ED treatment with either phosphodiesterase inhibitors or alprostadil. They have found 40% lower risk of hospitalization for heart failure and also 33% lower mortalities. So there seems to be some accumulating evidence of benefit of these agents used in ED medication for the benefit of cardiovascular disease patients. What about testosterone replacement therapy? Even though one of the pathophysiological mechanisms linking cardiovascular disease and ED has been the low testosterone levels, large studies, multiple studies have not conclusively shown that testosterone injections will benefit cardiovascular disease. So it is still up for grabs, and the actual effect is awaited. So what about when we go on to treat our ED patients with cardiovascular disease? As per the Princeton consensus recommendations, we are recommended to treat these patients by risk stratification. So it is very useful to get our cardiology colleagues on board, get them to risk stratify as low, intermediate or high risk patients. Obviously the high risk patients will need some treatment by our colleagues before we recommend treatment for them, while the low risk patients can have treatment very safely. And what are the treatments that are safe in these individuals? Again, I refer back to the blue pill, and we have now tadalafil, avanafil, vardenafil, etc. And sildenafil has been proven over and over again in very large meta-analysis, reviewing papers from the 1990s up to 2016. There are large meta-analyses which have come around and have proven that the rates of myocardial infarction and death are actually not worse in patients who receive these phosphodiesterase inhibitors compared to placebos. Now, of course, there are contraindications like the nitrates, and also in our practice, there is caution when we use these drugs with alpha blockers, the simple alpha blockers, the non-selective alpha blockers. It may be recommended to defer the drug usage by about 6 hours so as there is no orthostatic hypotension. Other modalities such as vacuum devices, intraurethral alprostadil or alprostadil intracavernosally can be very safely used in these patients. And of course, we should extend penile prosthesis to our patients with cardiovascular disease without hesitation. Of course, the caveat being that we must always think of these patients with organic disease as having a systemic illness and being at risk for cardiovascular disease as well. So proper assessment prior to any penile prosthesis insertion is very, very important, and getting our cardiology colleagues on board is extremely recommended. So ladies and gentlemen, increased disease burden in erectile dysfunction is going to affect us, and this is going to go parallelly with increase in cardiovascular disease. Erectile dysfunction is a fabulous indicator and should be utilized as a marker for cardiovascular disease, and it can precede the occurrence of cardiovascular disease symptoms by up to 2 to 5 years. And we can safely use PDE5 inhibitors on cardiovascular disease patients with a few limited contraindications, and the beneficial effects of phosphodiesterase inhibitors on the cardiovascular system data is emerging, and we should, as urological surgeons, offer the entire spectrum of treatment to these patients, even despite the fact of them having cardiovascular disease. I thank you for your patient listening. Thank you.